College in New York City. He's also the director of Platelet Disorder Center at the Weill Medical College since 2001. He's been an instrumental member in the many discoveries related to platelopathies in children, if you will. So, for example, in the early 80s, he participated on the first studies on the use of IVIG in the United States, as well as the use of anti-D in children, rituximab, and the newly licensed thrombopoietic agents, to name a few. He is extremely well published and well funded, and his publications go from Lancet, New England Journal, and you name it. He is a significant member, contributor of the American Society of Hematology, and we will have the pleasure of hearing Dr. Bussell today on the issue of TPO mimetics in children. So, Jim, the floor is yours. Many thanks for agreeing to talk to us in Canada today.
Well, thank you very much, Leo. Leo is being very kind about the introduction. I'm not double boarded. I have an appointment, a secondary appointment in OBGYN because of work with fetal thrombocytopenia, and a secondary appointment in medicine. I guess I was going to talk about thrombopoietic agents in children. So the first slide, is that visible, Leo?
Yes, it is.
Okay, thanks. So first slide sort of reviews the things I would like to talk about, and I'm going to put in just a small number, or I have in just a small number of introductory slides in the beginning, just for us to all be on the same page, if that's okay. On the next slide is my disclosures. Leo was very also over nice about saying I'm well funded. Nobody ever thinks they're well funded, but I've been fortunate in that area also. These are some of the companies I've worked with. The main ones we'll be talking about are the thrombopoietic agents are made by Amgen. That's for Mipplestim or Nplate. And it was GSK for Eltrombopag, Promacta, or Revolade, but recently Novartis took over that part of GSK's product line, or however you'd like to describe it. So it's really Amgen and Novartis now. Leo asked me to put in something of a CV, so some of this he's already covered. If you look at the different agents, the date in white is when I first started working with them, and the date is in orange is when we first published on them. I was fortunate in getting to be involved in the second generation thrombopoietic agents and ITP right at the beginning, and have worked with them since 2002. This is a schema of ITP, and this oversimplifies. It does emphasize the issue of impaired platelet production as well as accelerated platelet destruction. It totally leaves out all the complicated immunology that's evolving with T cells and other cells having an impact on the platelet count. To be fair, part of the reason I leave it out is I can't pretend that we understand it that well yet. This is a, This is a well-known slide, just points out that even though the platelets in green and ITP in the middle are low, the thrombopoietin levels are even lower, so that you could consider ITP to be relatively deficient, most patients, in thrombopoietin. This is a slide taken from one of our studies published in Blood in 2000, 11. And the point of it is that the y-axis is the maximum absolute immature platelet fraction, or absolute platelet retics. And these are 5 different agents that we're looking at on the bottom. So you see here 2 different thrombopoietic agents. AKR 501 is an experimental one. And you see that when patients respond, the absolute platelet retics go up a lot, whereas with Winrow, even when they respond, or IVIG in almost all cases, you don't get an increase in the platelet retics, even though the platelets go way up. So it's just to illustrate that these really do different things. This is just to remind you, I think we ran through some of the names already, but there's really 2 agents. They have different names, and I'm embarrassed to say I don't know for L-Trombopag if they use Promacta or Revolade in Canada. Promacta is the U.S. version, Revolade is the outside the U.S. version, and I'm not sure how that works.
I believe it's Revolade.
Okay. The 2 agents are a little different. The AMG 531 or romoplastin has 4 peptides that were picked up by screening. And in order to dimerize the receptors, there's 2 peptides here and 2 peptides here, just in case that's needed. These are glycine bridges and constant an FCR1 carrier domain to increase the half-life. Because of that carrier domain, it increases the half-life because it's recycled through FcRn, but that also means it would be likely to go across the placenta, so people avoid using it in pregnancy. This is L-Trombopag or Revolade. You can see how small it is compared to thrombopoietin itself. Because it's small, it's orally bioavailable, but it's inactivated by calcium and other cations. So it needs to be taken 2 hours removed from any food and 4 hours removed from, the easy way to think of calcium would be dairy, and also to try to avoid vitamins with, let's say, iron in them, or magnesium or other cations. Because it's so small, it also is thought that it would go across the placenta and also would not be used. Both of these agents stimulate via the thrombopoietin receptor, though it's thought that L-Trombopag binds in a region different from thrombopoietin itself. However, those differences mean that one agent could be effective when another isn't, and we'll come back to that at the end. Rather than try to review in great length the adult studies, I'm just going to run through them. The 5 in orange on this slide are the 5 largest randomized placebo-controlled trials ever conducted in ITP. So there's a very robust set of data, which is one of the reasons why I didn't really want to go through them individually. With romoplastin, there was initially a short-term study, which was published in the New England Journal in 2006, and then the pivotal trials published in the Lancet in 2008, and finally a study that was mostly in Europe but run by David Cooter here in the United States on seeing if you could avoid splenectomy using it, and that was published in the New England Journal in 2010. There was a long-term study published in the British Journal of Hematology in 2013 after the original, quote, long-term study was published in Blood in 2009. So there's data up to 5 or 6 years with this agent, and it looks reasonably safe. I'm going to come back to the pediatric data, in addition to obviously looking pretty effective. With Altrombopag, there was a short-term study published in the New England Journal in 2007, which was only carried out for 6 weeks, demonstrating that 50 and 75 milligrams were an effective dose. A confirmatory study was published in The Lancet in 2009, basically showing the same effects with a 60% response rate, whereas the earlier study had a 70 to 80% response rate. And the longer-term study was published in The Lancet in 2011, looking at treatment over 6 months and again showing efficacy. The long-term extension study for Altrombopag was published in Blood late in 2012, and now there's information up to 5 years or so with that as well. What you can say with all of these studies is that, first, some of the literature is confusing because, for example, if you say, well, they don't work as well in splenectomized patients, or if you say at least romoplastin doesn't, it's all about how you define the response. In general, if you're thinking of will they increase the platelet count in a clinically significant way, they would be effective in 60 to 90% of patients, and the toxicity is not high, and we'll come back to that at the end because that's a major advantage in pediatrics. So what about using TPO agents in children with ITP? Much of the data is still currently, quote, invisible, unquote, but some of it with Altrombopag will hopefully be published in the near future, and a large study with romoplastin has been completed and the data is being analyzed, and then that will be submitted. So I will tell you what I know are the results of these studies. So these are the first 2 studies that have been published. The first one was a small pilot study done with romoplastin, and I'll show you the data on that. It was randomized and double-blind. It had 17 patients with romoplastin and 5 on placebo, and was the basis for initiating long-term studies in children. The second study was our experience combined with Loan Shay's and Diane Nugent's experience, and that was published in the Journal of Pediatrics last year. This is taken from the randomized study, and even though the numbers are small, as we indicated, they've stood up in other studies, including, for example, ours, where you see with romoplastin there's a very high response rate, 88 to 83%, that it's effective across all different ages, 1 year to less than 3, 3 to less than 12, 12 to less than 18, and that in this definition of 50,000 2 weeks in a row, unaided by rescue treatment, the placebos do not have any response at all. This is another version of the same, looking at an increase of 20,000 instead of 50,000. And again, the responses are identical and the response rates are high. In our study with Diane, we had response rates slightly lower than this, so depending on what you used as the endpoint, there was no endpoint that was less than 62.5%, and some of the endpoints were higher than 80%. So clearly very effective in these studies. I show you these 2 slides to illustrate long-term efficacy. You see here these are children, and it starts with only 12, and by the time you get to 2 years, it falls off to 6. But you can see that one is able to maintain a count fairly well at a very good level. The dotted line is at 50,000. Of interest, if you look at the dose, over time the dose goes down, and this is not because of more difficult patients dropping out. This is rather the fact that it seems that patients are very slowly improving, given that there's a small improvement from the initiation of the long-term study to 1 year, and then a small additional improvement out to almost 2 years. These are the two pediatric studies that have been presented last year at EHA and this past year at ASH, and the manuscripts for both of these have been submitted, so we hope they will see the light of day soon. Just to make this clear, these are with eltrombopag, and they include 171 patients treated with eltrombopag. Now, this is a slide that I'm sure you are familiar with. I just want to point out a couple of things. First, we all know that kids with ITP tend to get better, but somewhere from 13 to 36% will progress to have chronic ITP, and many of those, not all, but many, will really need treatment. So we're honing in here on the most difficult to treat group. Second, both eltrombopag and romoplastin have been licensed in the US and the EU for at least 5 or 6 years, and both are now licensed in more than 90 countries worldwide. As part of the studies that are either completed or ongoing, there is a request for approval to both the EU and to the FDA in the United States, and I assume to the Canadian authorities as well, to allow treatment of children. The two studies differ slightly in that in the first study, patients with between 6 to 12 months with ITP could be treated. That's petite, whereas they had to have had ITP for over 12 months in petite 2. However, there were 87% of the patients in petite had ITP greater than 12 months, so functionally this is a study of children with ITP for more than 12 months. The proportion of patients, the endpoints were different. If you look at the bottom, you see that in petite, it was for the first 6 weeks after treatment, how many patients had at least one count greater than 50. In petite 2, it was for 12 weeks in the randomized phase, and it was requiring 6 of these 8 counts between weeks 5 and 12 to be over 50, and in both cases in the absence of rescue. I should point out that petite was initiated first, so the doses were lower for longer, and this, I believe, impacted the response rates. If you look up here for petite, 7 of 22 placebo patients responded, and we believe that's mostly related to URIs or other things that temporarily boosted the platelet count. But 28 of 45 eltrombopag patients, or 62%, responded. In petite 2, looking at the durable responses, there was 1 patient with placebo who got better, whereas there were 40% of patients with eltrombopag. And these numbers would be extremely similar to looking at the pivotal studies of romipilstim in adults, looking at the splenectomized patients. Both of these numbers were highly significant, demonstrating efficacy. You see here, if you look at the platelet counts, that in petite, you don't see as much difference until you get past 4 weeks. And this is because starting at a relatively low dose of eltrombopag and then only escalating the dose every 2 weeks, it took longer for the patients on active drug to get to a more effective regimen, which is why it looks this way. I didn't think I had time to show you all the data, but the response rates are similar across the 3 different age groups. The only thing in petite that's different is that the youngest kids had more placebo responses, and as indicated, we think that's due to infections. When you analyzed response to say, well, how many people responded at least for 3 weeks, how many people responded more at the end of therapy than the beginning, and other parameters like that that would indicate true responses, it made the difference between eltrombopag and placebo even more striking. Looking here at petite 2, you can see that the differences in platelet count between eltrombopag, again in blue, and placebo in red are bigger, and that's because petite 2 started after petite and was able to take advantage of some of the dosing information to start at higher doses. In this setting, that's why there was I believe, a more significant difference in responses. In petite, it turned out that we were able to include PK data, and that suggested that even though younger patients required a higher dose in terms of milligrams per kilogram than adults, at least 2 to 3 milligrams per kilogram, they also seemed to require a higher blood level to have an equivalent degree of response, suggesting that maybe children were a little less susceptible to these medications. But again, that didn't translate to any increase in toxicity, as we'll look at. So the take-home messages from these studies are that in both of the open label responses at the end, more than 80% of the patients in both petite and petite 2 responded to greater than 50,000 at least once, and almost half the patients responded for half the time in the open label part in each study. Important were that there were no thromboembolic events observed in either study, and no induction of malignancy was seen. And you could say, oh, well, there were only 171 patients treated, but still, that's a significant number, and the numbers for this are clearly higher in the adult population. In contrast, the transaminase elevations, which is the reason to monitor the liver test for eltrombopag, were observed in 3 to 8% of the patients, and this is very similar to adults as far as having to discontinue patients because their transaminases stayed elevated. I should point out that since, for example, the URI or something else can elevate transaminases, if you're treating somebody and they're doing well, or you really want this to be the treatment, and the transaminases get elevated, if you stop the eltrombopag and wait, first of all, virtually always the transaminases will return to baseline. And if they do, at least half the time in the adult studies, you could resume treatment safely with eltrombopag. The other point I would say here is that there are no transaminase issues with Nplate, but it is a weekly injection, but you could go to that if you wanted to. Now, in the wrap-up phase, here you can see that in white are the theoretical side effects of treatment, and in orange are actual side effects. In adults, even though thrombosis has not been significantly more frequent in the treatment arm than in the placebo arm in any of the randomized studies, I believe that's the most significant side effect that a typical ITP patient could have. And both long-term studies in adults have a 6% thrombosis rate. As indicated, there is yet to be a child with thrombosis treated with eltrombopag or romoplastin, except for one of ours, who had a thrombosis right where she injured herself and fractured her ankle, and had has been on eltrombopag for probably an additional 2 years now without any recurrence. In adults, also, you worry that maybe a patient with difficult ITP has at least a component of MDS and therefore may have induction of malignancy with these growth factors. However, again, that's pretty much a non-starter in kids. So is another reason why I actually think the thrombopoietic agents are safer and better in children than they are in adults. I'll point out one more thing about this at the end. Now, finally, as far as toxicity is concerned, people have worried about bone marrow scarring. The only data published in children so far, and the only data that's come out and will come out anytime soon, is our data in the Journal of Peds last year, and it seemed that it was pretty safe, and in 24 marrows, there was only one grade 2 fibrosis. In general, also, this is reversible, and we believe that it's reversible because you don't induce the cross-linker of the collagen so that it's not socked in and can disappear or dissolve when treatment is stopped. This is just to illustrate, you see the black lines are fibrosis, and this is reticulin as opposed to collagen, and one can monitor this and look at it. The ongoing romoplastin study that just started is doing bone marrows in the European centers and will therefore provide some prospective data on marrows in children treated with romoplastin. So we talked about this a little bit. What's different about TPO agents in pediatrics? I think it's clear that for eltrombopag, you need a higher dose per kilogram body weight than you do in an adult. I almost think you could treat all kids and all adults with 50 or 75 milligrams and then adjust based on the platelet response. It's not as clear that this is true for romoplastin, but it does seem to be in more limited data. There's the romoplastin study that just finished that had 62 patients in it that was randomized, and that study will provide more data on this. As indicated, that's being analyzed, and preliminary results are not available. In regard to eltrombopag, there's the issue of the dietary restrictions we talked about. So normally you would give this at bedtime. If you have a small child, they can go to sleep and the parent can give it to them prior to the parent going to bed. In the trials, they had a liquid form. It was powder that was dissolved. As part of applying for use in children, GSK, now Novartis, is applying for the use of this powdered form as well. And we discussed thrombosis and malignancy considerations. So what about using these in practice? The count will increase in about a week if you give a dose to which the patient's going to respond. If, for example, you follow the, quote, package insert with romoplastin and give 1 microgram per kilogram, and then go to 2, and then go to 3, and then go to 4, it can take quite a while. So even though it's not indicated, personally, I would start with 3, go to 5, go to 7, go to 10, but that's just my opinion. Because usually if you want it to work, you don't want to wait 2 months to find out if it will. As indicated, in children and in adults, the response rate is 60 to 90%. Now, there's increasing anecdotal data that if, for example, you treated a patient or a patient has been treated with one agent and it didn't work, we don't know if they'll respond to the other agent. There's some published data now showing anecdotally that one thing will respond and another and one patient will not respond to one and then respond to the other. This remains to be seen and presumably is explained by the different binding to the thrombopoietin receptor. The question of improvement with use, we don't really know, but I think 30 to 40% at 6 to 24 months is probably a safe bet. And the earlier that you start them, the more likely it is a patient will get better. There's no information as to whether this is just you're giving them a good count and they're improving with time, or there's another mechanism at play, such as induction of Tregs. This is an area that's going to definitely take a while to work out. There has been a recent study in adults also suggesting a curative effect, but it's very hard to know. Finally, because these agents have unique mechanistic effects, they work well with other treatments that focus more on interrupting destruction of platelets. Second to last or third to last slide, what else could you use these in? Well, at least in the United States, eltrombopag is licensed not only for ITP, but for hepatitis C. However, as you, I'm sure, know, the newer treatment agents for hepatitis C do not induce thrombocytopenia. So the utility of these agents to support the platelet count is less, and one study showed that the risk of thrombosis in a cirrhotic patient can be high. So if they're used for thrombocytopenia in the setting of liver failure, they should be used with caution. They've not been licensed for MDS, and part of the reason for that is induction of malignancy. There's publications now in myosin heavy chain 9 disease, MYH9. We used to call the main form of that May-Hegelin. And Carlo Baldwini published in Blood several years ago utility of treatment with eltrombopag. We have a manuscript that we think is in press looking at eltrombopag and Wiskott-Aldrich, especially in the XLT version. There's no work ongoing yet on platelet donation, but clearly this would be a home run for blood banking if anybody's experiencing a platelet shortage, but was the area where the normal donors ran into trouble with the first generation agents, so it hasn't really been looked at. And finally, it was recently licensed for the treatment of aplastic anemia. There are no ongoing and have not been any completed randomized studies comparing, for example, immunosuppression, i.e. ATG and cyclosporin, with immunosuppression plus eltrombopag. There have been historic studies comparing to historical controls, and it seems that eltrombopag at least is very effective in this setting. I had heard that there might be a European transplant consortium study that would look at this, but I'm not sure about that. In chemotherapy, it's clear that for AML or other myeloablative settings, the TPO agents are very unlikely to be effective. But in solid tumor chemotherapy, in the same way that GCSF might allow a better dose intensity by keeping the patient on schedule, these agents may do that also. And finally, there's a lot of interest in the stem cell transplantation area, both for use after transplant and for use in ex vivo expansion, but this is still a field that's being developed. So this is my last slide, and this is just to say that sometimes when you take care of ITP, it seems like it's the common cold in comparison to taking care of cancer. But I hope I presented you some information in a usable form, and I'm hoping we can do questions. Thank you very much.
Thank you very much to Dr. Bussell for this wonderful overview of the use of TPO mimetics in children. As stated before, let's go through the centers that we can currently see present on the webinar. If you will, I'll start with, again, Dr. John Wu from BC Children's Vancouver. John, good afternoon. Any comments from your end? We don't see any comments, even though there is a mic. Your mic is open, John. If not, maybe we'll move a little bit out east to Calgary now. And let's see if we have questions from anybody from Calgary Children, Alberta Children's. I'll open more mics from Alberta. Let's see. No questions there. Then we'll go to Saskatoon. Dr. Senia, Runa, do you have any questions for us?
I guess my only question would be, between the two drugs, how do you decide which one to use first?
That's a really good question about which one to use. In the United States, we have something to worry about that I think you don't have to worry about, and that's insurance. So different people's insurance will cover one of them better than the other. If you had a choice of either of them, I would normally talk to the parents and let them choose. Most people would choose the oral agent, but like we talked about, if you had somebody who travels or is not home all the time, doesn't eat dinner at the same time, wants to go out and party, etc., like many adolescents, it's probably easier for them to get romoplostin and just put up with getting a shot once a week. In the U.S., you're still not allowed to let them or their parents or somebody learn to do it on home care. I think in the EU you actually are, so I'm not sure what the situation is in Canada, but I think that would be another factor that would matter depending.
And sorry, another question. So the L-Tromba bag, can you get that? You said they were developing a powder, but are there forms for kids that you can give?
They have tablets down to 12.5 milligrams. My experience is that means that kids somewhere between 5 and 10 will start to be able to take tablets. They're not especially big, they're not bad tasting, and they don't upset your stomach. So generally, there's nothing especially difficult about taking them. So if a kid can take tablets, it's fine. The sachets where, they have powder and you dissolve it and you give a certain amount of liquid allow you to control the dose better and allow you to give a dose to a smaller child. And I think those will be available, let's say, within a year, I would hope at the latest.
Okay, thank you very much. We have several questions from the audience that I can identify. John, sorry, we may have missed you. Dr. Wu from BC Children's had questions about experiences with Canada, with funding in Canada. I'll just preface, Dr. Bussell, I looked at the prices and available formulations in Canada today, Jim. L-Trombopag, one box with 14 tabs, each tab containing 25 milligrams, is coming at $923. Conversely, romiplastin, 0.5 mLs equivalent to 250 mics, is equivalent to 1,000 Canadian dollars. And I don't know if Dr. Bussell would have any comment regarding funding for these agents in Canada.
The only thing I would say is with the numbers you just gave me, the $1,000 for romoplastin would be one dose because these are not multiple use vials. And the 14 tablets of 25 milligrams, maybe you're talking 5 to 7 doses, depending on how much the child is going to use. So it's pretty expensive either way.
Okay. Now, let's see if, I don't know if Mike Leaker has a mic that he can brought some of the questions he sent. Mike, do you have a mic in front of you? If not, I'll just read. The question one from Mike Leaker would be, if anyone, just one second, has anyone observed remission of ITP after discontinuation of TPO mimetic? I think you've brushed on some of these points after 6 to 24 months of use. Dr. Bussell, do you want to comment on that?
We initially participated in a study in adults with an agent that's still experimental, and they didn't have a long-term treatment planned. So we had to cold turkey people, and much to my surprise, something like 25 to 40% of them did okay. That induced us to do a study that we call End of Extend, which is kind of a stupid name, but it's about trying to slowly discontinue people. And I think, as you indicated, Leo, there's some degree of success, but certainly not everybody. And I usually would tell a patient, if I was starting them, that they might have to be on 6 months, 1 year, 2 or 3 years, 5 years, or even longer, but we believe that most people would eventually get better. I don't know if that's satisfactory, but there's really not great data yet.
Okay. Let me address another of several questions we're receiving. If you can expand on why a patient may respond to one of the agents and not the other, as there seems to be case reports of this occurring in the adult literature.
I apologize because I was trying to not have too many slides, and I left out a slide, well, 2 slides that would have illustrated how they each bind. We think that romoplastin binds to the exact site that thrombopoietin binds in the outer part of the receptor. We know that there is a polymorphism, or a polymorphism in the transmembrane domain of the TPO receptor, and histidine or lysine determines whether or not L-trombopag will bind to it. It's not been formally proven that the binding is in that region, but it's been presumed that that's where it is. The fact that these agents work differently, and for example, that L-trombopag can actually serve as a chelator as part of the binding to calcium or even binding iron, is something that people are beginning to study. So these clearly are different molecules, but exactly what the biology is and why they're different isn't known. I think the differences that are been reported in adults, and probably the best article is from the French group from Medicalop in Hematologica in 2013. The differences, I think, reflect that there must be a difference in the biology, but exactly what that is being studied.
Thank you. I think that probably some of your questions have brushed also on perhaps a more direct question. If it was for one to choose between Romi versus a trombopag in a patient, which one would be chosen?
Like I said, when I offer the choice to most patients, they're going to choose L-trombopag because it's once a day oral, unless there's a reason not to. And in our setting, sometimes that reason could be insurance, and it also could be all the issues related to diet, or to having liver disease or being concerned about liver disease. I tend to believe if I had to choose only one, I would probably pick romoplastin, in that it might be slightly more effective, but there's really no data, and all the studies suggest that they're about equally effective.
Okay. Let me open the mic for now moving far back to east to Dr. Vicky Price. She has a question on the screen, but maybe she's still in front of the mic to ask herself. Hi, Vicky. How are you? If she doesn't have access, I'll ask. It it relates to cases, Dr. Bussell, where perhaps patients have on and off have a changing severity of thrombocytopenia. They have thrombocytopenia, they have ITP, but then with intermittent infection, maybe their severity of their thrombocytopenia worsens. So if there is any role or indication for intermittent use of these agents in such instances.
I think the problem, at least the way my experience would go with that, and I might be mischaracterizing it, is let's say somebody gets a cold, a patient with ITP, and their count starts to go down. Even if you started one or the other agent, then it would take a week to work. So I'm not sure you would really blunt very much of the low count, which I assume would be the intent. I would think in that setting that either giving IVIG, giving steroids, or just riding it out, or giving perhaps an antifibrinolytic agent might be a more effective strategy. If we're talking about somebody who tends to be stable, but then when they get a cold and the count drops, it stays down for a while, then that's a different setting. And the other thing would be if somebody's going to be in a situation where their count might drop for any reason, including everybody at home is sick or something like that, if you have a little more notice, then that could be an effective use also.
Excellent. Let me hopefully finish the Q&A session by opening the floor to the Sick Kids attendees. Would there be comments or questions to Dr. Bussell here in Toronto? And if so, please allow me to remind you to come to the mic so that everybody can follow that.
In one of the slides, there were reticulocytes response and in different conditions. Is there any correlation between reticulocyte response and clinical response?
We've been trying to look at that and haven't really seen. I think you mean this one, right?
Yes.
So this is not so much different conditions as different treatments. When we've looked at a large series of patients, and we're still trying to work on this study, and we've collaborated on this with HUE in Toronto to look at antibodies to GPE 2B3A versus 1B9, we still are not completely finished analyzing if there's a relationship or not. We weren't sure initially if low platelet retics would be the people who would respond best, or those would be the people who had trouble making platelets even with stimulation, and high platelet retics would be the people who responded best. In general, it seems like the latter is more true than the former, but we're trying to get the data more solidly analyzed and look at some other factors to see what determines that being response to a TPO agent.
So there's a few more questions from Sick Kids. This is Manuel Carcao. One question is, when do you decide if a patient is not responding, and at that point you decide to stop? And then the second question is, in terms of dosing, for chronic ITP versus for some of the other conditions, such as the congenital thrombocytopenias, and specifically an MYH9 macrothrombocytopenia, is the dosing the same, or do they require different dosing?
So let me take the second question first, because I think we don't really know the answer. I think in the data that we hope will be coming out in Wiskott-Aldrich, it seems that they don't respond as well, which would support the idea that there's a marrow component to the thrombocytopenia in Wiskott-Aldrich. In MYH9, I think the doses to me in the one study from Professor Baldwini in which 12 of 15 patients responded, the data to me looked like the doses were pretty much identical to what you would see in chronic ITP. I apologize. Oh, let me make one more comment on that. I meant to make it earlier. One thing that's a little, that's important about treating inherited thrombocytopenia is that a number of the conditions are potentially pre-malignant. The most obvious are the familial thrombocytopenia leukemia syndrome and the ANKRD26, both of which are in the same pathway. So I would be very reluctant, like in a MDS patient, to treat them with a TPO agent for fear of inducing a malignancy. And you said in the first question, how do you know when to stop? When are they not responding? Theoretically, if you're giving them the highest dose for 4 to 6 weeks, that would be the definition of stopping. Personally, what we would do, and again, you could argue that this is too expensive an approach, what we would typically do would be to add an agent, not to stop the TPO agent. And the rationale would be, in the non-responders in our clinical experience, and in the ones published in that same article in Blood in 2011 that looked at platelet retics, the patients who don't respond seem to have good megakaryocyte responses, and it seems to be more a question of being unable to get the platelets out of the marrow. So we think that if you stimulate platelet production and add something that will inhibit destruction, that works pretty well. I would say my favorite in a really difficult patient would be to add cyclosporin, because that seems to be the combination most likely to work. But as I'm sure all of you know, and it applies, I'm sure, not just to ITP, nothing works in everybody.
Yes. Manuel, before we go forward with the kids, I think we may have a question from Ottawa. Let me see if we can open.
Leo, I want to get a question into Jim.
Oh, well, just give me one sec, Dr. B. Let me just see if I have anybody from CHIO to ask us something. Melissa, do you have a question for us?
Yeah, hi Jim. It's Rob Clausen calling. I was very interested to hear about the GSK Eltrombopag being approved for aplastic anemia. How do you see that working, and how do you work that in? Is it only the kids who failed immunosuppression or who are not eligible for transplant, or like how does it work?
I think that how it works is that the hypothesis, according to Neil Young and Cindy Dunbar, who are the leaders in this area, is that the immune attack on the marrow is knocking out the stem cells. So if you can blunt the immune attack, for example, with immunosuppressive agents, and then stimulate the stem cells, you'll get a response. As I suspect you probably know from the New England Journal article that I think is almost 2 years ago now, they not only had responses in 9 of 25 patients for platelets, but had responses for red cells and granulocytes in 6 and 7 patients. That speaks to the idea that the TPO receptor is thought to be more important and occur earlier on the stem cell than even the GCSF receptor. That also goes, and again, Rob, I know how you know this, that in congenital deficiency of the TPO receptor, namely congenital amegakaryocytic thrombocytopenia, they commonly, if not almost always, progress to full aplastic anemia, which is thought to be from stem cell exhaustion. In the studies they did, the big worry is that they induced monosomy 7 and other cytogenetic changes in not a small number of patients. I'm not absolutely sure, but it was either 7 or 9 in their first 40-some patients that they treated. They feel that that was present anyway and couldn't be detected pre-treatment because there weren't enough stem cells that could be mobilized or enough cells that were replicating to be able to see it. So they were just amplifying something that was there anyway. That remains to be seen, but I think they really need to do a controlled trial to see what's going on. I don't know if that answered your question, Rob.
No, thanks. I had some concerns myself, so it's good to hear it from you.
And I don't think, by the way, that anybody knows where in pediatric patients to use it. And I'm not absolutely sure, but Philip Scheinberg, who was at the NIH and was part of these studies and is now back in Brazil, I think might be doing a pediatric study there, but I'm not completely sure.
Perhaps we can finish with Dr. Whitlock's question. Dr. Blanchette, back to Toronto.
Jim, enjoy that. It's Victor. My question for you is, if you take primary childhood ITP that's gone beyond the newly presenting case and is out in persistent, and you're thinking about it as a splenectomy sparing strategy. So you got this kid, you know, I got a couple now, you've all got them. So they'll respond to steroids transiently or IVIG, but you're getting very short times, and then they're sitting on the 10,000. So I got a couple cruising around that 1,000, 2,000, you know. So you got to be worried. So now you're thinking of something which is second line, and the options are a lot, but let's just throw the three on the table. Oral MMF, a course of rituximab, whatever you choose, or one of these agents. And if we put aside now, you know, their availability, being licensed, or costs, in that stepladder situation, which would you choose?
Well, first of all, Victor, since I know that you know about as much about this as I do and have been involved in ITP as long as I have, how about telling me which you would choose, and I promise to give you an answer that won't be thrown off by whatever you say.
Well, okay, so if, with the caveats of putting aside the pre-licensure and cost, which you can't do, so this is kind of utopia, I would use a thrombopoietin, because I think the data says it's about, you know, 60 to 80%. That will get you into account that you will be more comfortable with the risk of intracranial or lifestyle, and then you hope natural history is on your side. You know, rituximab is not a friendly drug, and it has some other things. And MMF, if you're down in Toronto, we got a lot of skeptics. They don't believe it works, but I think it's not a bad drug. So that's my suggestion.
I mean, to me, that sounds right. I would just throw one thing out there. When we use Rituxan, for the reasons of the long-term data, a whole group of us published back in 2012, and that was sort of reinforced by Walid Ghanima's study in The Lancet, showing relatively limited benefit of rituximab. When we give rituximab, we do it with 3 cycles of Dex, and we published on that in last summer in Hematologica. As we analyzed more kids with more follow-up, what we find is that if you have a woman, a female, an adolescent female, or a girl with persistent or even with persistent ITP less than a year, and you use dexamethasone with the rituximab, they're very likely to be cured by that, as opposed to a boy or an adolescent male, however you want to call it, who may respond well, but then will almost always eventually relapse. So to some extent, that would color my judgment on what to do. But if you're saying you don't want to use rituximab for any of a lot of reasons, including the risk of the JC virus and PML, even though I personally think that's very small, then you could say, look, this is by far the easiest way to get the count up and meet all the criteria you elucidated about quality of life, as Rob has described, and so on. and it would work probably by far the most frequently. So hard to disagree.
Great, thank you.
With those comments, I think it just speaks to the level of the symposium and interest. We have passed 8 minutes from the hour. I would greatly appreciate the disposition of Dr. Bussell to talk to us this afternoon, thanking him one more time, and inviting everybody to fill your evaluations on your way out of logging from the webinar. Thank you very much, Dr. Bussell.
Thank you, Leo, and thank you, everybody.